Good evening, everyone, and welcome to our webinar hosted by MedStar Montgomery Medical Center. My name is Tanya Paler, and I am the Director of Marketing and Communications. And I'm really looking forward to our program this evening in honor of Breast Cancer Awareness Month. While this event looks a little different than past years, tonight we will hear from an impressive panel of our providers who will address the topics and questions that are most important to you, from prevention to treatment and recovery. Before we jump into our program tonight, I do have a few housekeeping items to mention. At the end of the presentation, please feel free to ask questions of any of the doctors with us tonight. To ask a question, simply click on the Q&A button that you see at the bottom of my screen. We will do our very best to answer as many questions as we can. Additionally, our panelists cannot give individual medical advice here tonight. So, if your question is better addressed directly with the physician, we will provide the appropriate contact information and ask that you reach out to schedule an appointment to speak with them. All right, I'm excited to introduce you to our wonderful guest host this evening, Kristen Bressette-Harris. She is an award-winning host of WUSA 9's Great Day Washington and has an incredible story of thriving, as she is a two-time breast cancer survivor. Kristen was first diagnosed at the age of 27 and later re-diagnosed in 2016. Now she is a strong advocate for awareness and early detection. Thank you, Kristen, for being here this evening.
Tanya, thanks so much. And hello, everybody. I'm so excited to be here to be discussing such an important topic. Obviously, as you heard, very close to me, but something that we've all been affected by. And it's such an important time as well. I echo your excitement and so glad all of you are here. And while we talk so much about cancer detection and breast health, this year, of course, has been particularly challenging for patients, survivors, caregivers, physicians, all of us. So that's exactly what we are going to talk about tonight. Breast cancer in the time of COVID-19, what we need to know, and really how to remain healthy during this pandemic. Now, before I introduce you to our amazing panelists that we have tonight, we're going to start by sharing a video that highlights the compassionate, multidisciplinary cancer care program at MedStar Montgomery and continues to celebrate the world-class care right here in Olney, Maryland with the opening of the Women's Breast Health and Imaging Center. Roll the tape.
I'm excited about being a part of the Breast Health Center here at MedStar Montgomery Medical Center because it brings state-of-the-art multidisciplinary breast health care to the women of Montgomery County.
Over the last 10, 20 years, the field has expanded a lot. Better care, better treatments, giving them more opportunity to beat the cancer.
And it is very convenient for patients and their families to be able to get very high quality care close to their home.
Once you have a diagnosis, I talk to the patient and educate them about what that means for them and give them options, because we're no longer in the era where one surgery fits all patients. It's always such a personal thing with surgery, especially breast cancer. So I want to make sure that we give them the best surgical outcome, but also the best oncologic outcome.
I think the great thing about being a reconstructive surgeon is I'm able to use new techniques and new technologies to help women really feel natural and normal after going through breast cancer care. And that sense of normalcy is really the goal.
MedStar Montgomery is an extension of the MedStar Georgetown Cancer Institute. What that means for our patients is that we are able to give them access to state-of-the-art treatment that would only be offered in an academic center, access to things like clinical trials, very specialized types of care that would not necessarily be offered usually in the community setting.
This is a huge advantage to have a full range of top-notch facilities and people locally to provide care. At the same time, have the opportunity to connect within the network for a highly specialized care.
Breast imaging in particular is really rewarding because we know that screening mammography has been shown to decrease breast cancer deaths by up to 30 to 40%. And I think that's fascinating, to be able to find disease in someone who's not having any symptoms of that disease and to treat and cure them before it affects their lives.
So at MedStar Montgomery Breast Health and Imaging Center, we have what women have been asking for, a more comfortable mammogram. We have Hologic Smart Curve technology where 93% of women reported an increase in comfort. This is due to the curved design of the paddle that distributes pressure more evenly, resulting in less pinching. That, coupled with their 3D Genius system that allows for the least amount of time under compression, is why the system delivers what women have been asking for.
All of our patients newly diagnosed with breast cancer are recommended for genetic testing because that can help to inform us on potential variations in the treatment that might be most helpful for them. It also helps us to determine what types of surgery they might need and even to inform family members on any specific testing they might need as well to make sure they stay safe.
The Breast Health Center combines the entire team under one roof and to collaborate and provide the best care to help women return to a sense of wholeness, return to a sense of femininity, and really put cancer behind them.
What an incredible video and a great way really to welcome our robust team of experts that are here with us tonight. So let's meet our panelists, many of which you will recognize from the video that you just watched. I'm excited to be joining them tonight. We have Dr. Jennifer Sun, a breast surgeon, a fellowship-trained breast surgical oncologist who specializes in minimally invasive breast cancer surgery. Dr. Judy Song. Dr. Song is the Chief of Breast Imaging and Assistant Professor of Radiology. Her clinical focus includes breast cancer screening and diagnosis. Her research interests include ethnic disparities in breast cancer and exploring how to overcome socioeconomic barriers to healthcare. Dr. Robert Howard. Dr. Howard is a board-certified plastic and reconstructive surgeon and retired U.S. Navy captain. He specializes in reconstructive microsurgery and wound healing. Dr. Nora Sudarsan, hematology oncology. Dr. Sudarsan is a board-certified hematologist and medical oncologist who specializes in cancers of the breast. Dr. Benzad Daradotaj, a fellowship-trained hematologist and oncologist who treats a full range of breast diseases as well as other cancers and blood disorders. And Dr. Luther Ampe. Dr. Ampe is fellowship-trained radiation oncologist and director of MedStar Montgomery's Cancer Center. He has also been recognized multiple times as top doctor by Washington Magazine. So again, an incredible group of panelists here tonight, and we're going to get to so many different topics. Thank you all for being here. We're going to hear from each one of you. So I'm going to get right in to question one. So with that, here we go. Because I think it's really one of the most important ones right now, and certainly at the forefront of all of our minds. For those who might be anxious about returning to a clinical environment or might consider delaying screenings due to fear of contracting COVID-19, Dr. Sun, this is for you. What do you tell these individuals? Are they safe to return to the hospital?
They're absolutely safe to return to the hospital. I mean, I feel like back in February when it was such an acute issue, everyone is putting things on hold, but unfortunately now COVID-19 is here with us for quite some time, and so we have to learn to live with it, to coexist with it, and for that reason everyone is more prepared to be able to deal with this, in addition
to get people's screening on time. And so people are being tested before they come into surgery, for example. Everyone's wearing masks, and we're also wearing eye protective shields. And so for all these reasons, we should not be delaying care. We can learn to work together to be able to prevent contamination as well.
Awesome. So come in, get your screening, get your care, and know that it's being done safely. Yes, this pandemic has already really compounded an already very difficult journey for so many women and their loved ones. With that, we are going to test everybody's breast health knowledge tonight. So there's going to be a few poll questions for you guys to answer, just some trivia questions, really to see how well everyone has been listening to the doctors, but also maybe some things you didn't know, or just a good refresher. So we're going to be popping these up just like this. And here's your first poll question. How often should women over the age of 40 get a mammogram? I'm going to let everybody take a little moment to vote. Your options: every other year, yearly, or every 5 years. The answer for this first question is annually for most women. Speak to your doctor to make a decision that is right for you. All right, I'm going to throw this next question to Dr. Song to answer. Dr. Song, what are the recommended screening guidelines? Does breast augmentation affect mammography?
This is a great question, and I think that many women are confused because there's been a lot of information out there. Now, this slide shows you that this is the current recommendation from many of the clinical practice societies, including the American College of Obstetricians and Gynecologists, and I apologize, I am in my office and I forgot to mute my phone, as well as the American College of Family Practice Physicians. It is important to note that all of these guidelines do specify that women should have the option of beginning at the age of 40. And this is important because this is for average risk women. We at the American College of Radiology, the Society of Breast Imaging, do recommend that women undergo annual screening mammography beginning at the age of 40. And in certain cases, we say average risks because there are patients who should start earlier, and some patients should get supplemental screening not only with mammogram but also with MRI and whole breast ultrasound. So the most important takeaway is, yes, you should be having these discussions with your physicians beginning at the age of 40, and more importantly, every woman should know your risk.
Thank you, Dr. Sun. Thank you for clarifying and reminding us all the importance of the screening. All right, let's do another poll question for all of you. So get those clicks ready. If I have a family, or let's see, how are we going straight to, I want to make sure we get the right ones here. Okay, you've got the breast care. Let's go to this question that we have. How do you determine if an individual needs surgery, chemotherapy, or all three?
Well, we always look at each individual case because everyone's unique. Everyone's cancer is unique, anatomy is unique, genetics is unique, and so we all work together in a multidisciplinary fashion. And what that means is that we're always all in communication with each other. We don't just refer you out and say, come back when you're done. We're always in constant communication to talk about your individual case. And so that's what a true multidisciplinary setting is. And so we always want to personalize your care. So some people may have surgery and then chemo. Some people may have chemo and then surgery. Again, it all depends on your individual pathology, on your goals, and we all talk with each other to give you the best outcome.
Dr. Sun, thank you so very much. I skipped ahead, so I appreciate you being there on the ready. Now is the time for that next poll question. If I have a family history of breast cancer, I'll definitely get cancer. True or false? I give you guys a few moments to put your answers in there. If I have a family history of breast cancer, I'll definitely get cancer. True or false? Now this is false. correct, Dr. Sudarshan? Does having a family history of breast cancer increase my risk for getting cancer? What is the latest you can tell us on the BRCA gene testing?
Thanks. This is a great question again, Kristen. Having a family history of breast cancer certainly does not mean you will get breast cancer yourself. We recommend that if you have a strong family history of breast cancer, genetic testing be performed to help assess your risk. If you do carry a genetic mutation, such as a BRCA1 or BRCA2, we know that you have a much higher risk of breast cancer and thus recommend different screening tests and possibly certain surgeries or treatments that will reduce your risk. However, only 5 to 10% of women with breast cancer have one of these genetic mutations. It is thought that even in the absence of mutations, those with first-degree relatives who have had breast cancer, like one's mother or siblings, likely do have some increased risk of breast cancer and should therefore be more vigilant. Unfortunately, breast cancer is just common. 1 in 8 women will get breast cancer during their lifetime. This illustrates how important it is for all women, even those with no family history of breast cancer, to undergo annual screening mammograms so that if a breast cancer is ultimately found, it will be found earlier and hopefully with a high chance of being cured.
Dr. Sudarshan, thanks so much. Knowing your risk, knowing your body, and knowing your family history, so very important. Our next question, I know we often hear that there is no one-size-fits-all treatment plan. I think any of us that have been through that realize that and understand that, but that was very clear to me during my recent diagnosis. One oncologist told me chemo, one told me not. It was all by the studies, you know, the years, everything's always changing. So it's not one size fits all. Dr. D, can you take some time to talk about patient advocacy and what a patient's role should be in their care? Dr. Durataj?
Thank you, Kristen. This is a very important question. So the patient is the center of the care. Actually, I would say that the patient is the captain of the ship. Without the captain of the ship on board, the ship would not sail. Every member of the care team, along with the family members, should actually strive hard to have the patients informed and make sure that they make the decision, let them make the decisions in their cancer journey. With regards to what the role of the patient is, patients should be engaged. They really should ask, and all the questions that are important in decision making and don't hold back. Also, they should make sure they use every tool to reduce the stress level, and then just be active and then move along.
Wonderful. All right, we have another poll question for everybody, and Dr. D, maybe you can answer, give us some insight on this as well. True or false, breast cancer always forms a lump in the breast? And give you guys a few moments to answer that question. Of course, you hear that a lot. I know that's how I found mine, was by feeling something in my breast, but I also felt one under my armpit. But Dr. D, breast cancer, does it always form a lump in the breast?
No, it is false, and it's a very, very important question. So breast cancer can, present in all the different shapes and forms. It could be a simple pain on the breast. It could be just a dimpling in the skin. A heart knot, like under the armpit, for example. Like there could be a rash or a nipple retraction. So there are different symptoms, and signs that can be related to breast cancer. So it does not always present with a lump.
Great, thank you for the great information. Now, I know during some of my past treatments, one of the things that was really important to me was to incorporate lifestyle changes, holistic treatments, and exercise along with the clinical care. It was important for my quality of life, important, to keep me healthy in the long run. So can one of you speak to the importance of support services and how you work with women to determine the best services for their health goals?
Yes, thank you, Kristen. So in our oncology program at MedStar Montgomery, we emphasize treating the whole patient. We work as a team made up of social workers, financial navigators, physical therapists, nutritionists, and integrative medicine providers to identify the services that would be best to support each patient's individualized health goals. We then coordinate care to ensure our patients get well soon while having as smooth of a treatment journey as possible. This holistic approach to care addresses and minimizes side effects from other necessary components of treatment, such as surgeries, radiation, or chemotherapy. It's our experience that by supporting patients with personalized, comprehensive care, we can also improve their overall well-being and reduce stress and financial toxicity.
Such great things to talk to your doctor about, great things to incorporate in your life, Dr. Sudarshan. Thanks so much. Our next question, Dr. Howard, I'm coming to you. If a woman is interested, when do you advise a patient to begin planning breast reconstruction? Do I have to have completed cancer treatment first? How do you advise your patients?
Well, in most cases, breast reconstruction can start in concert with the oncologic surgery. There's rare cases with aggressive cancers where we might want to delay reconstruction, but for the most part, we begin reconstruction with either breast conserving therapies, such as partial mastectomies, what's called a lumpectomy, or even with mastectomy. And beginning the process with mastectomy at the time of the oncologic surgery can really reduce the number of times that a woman has to go to the operating room. All breast reconstruction does tend to happen in stages. We don't have really a one surgery reconstruction at this point. So it's just something to think about, but we do like to start as soon as we can and really, maintain a breast form through cancer treatment.
Thank you, Dr. Howard. Now, if anyone, we want to remind everybody, if any of you have questions for any of our doctors from anything you've heard tonight or something you would like their expert advice on, please go ahead, submit them now using the Q&A feature. You'll see that on your screen, the Q&A feature, and we'll try and get to as many of your questions as possible when our doctors are done with my questions. So we're going to keep going with my questions. This one is for you, Dr. Ampe. We saw in the video earlier that the hospital's affiliation with MedStar Georgetown Cancer Institute. What does this mean for the patients in terms of access to best-in-class care, resources, advancement in technology, clinical trials, and the latest research? What does this affiliation do for the patients?
Thank you for the question, Christian. This topic was touched on by Dr. Sudarshan in her video early on. And fortunately for us as clinicians and you as patients and consumers, we enjoy a very close relationship with our colleagues throughout the MGCI, MedStar's Oncology Network, with its NCI designated research engine, the Lombardi Cancer Center, as the hub. This affiliation affords our community's patients seamless access to subspecialists in many areas of cancer management and access to enrollment in leading clinical trials. Our providers here can collaborate not just with one another, but others throughout the network, including those at MedStar Georgetown and MedStar Washington Hospital, to provide the best management options for our patients.
Dr. Ampe, thanks so much. And thank you to all of the doctors for giving us that important information that we need. Reminder, you can ask your questions. I do have a question. I have a very close friend. Both my cousin and my cousin's wife have gone through this. And I just wanted to say my cousin, because of my journey, made sure to get her mammograms starting at 40 yearly, and then this year at 42, they found a lump in her breast. But thankfully, because she was on top of her screening and in touch with the doctors and paying attention to her body, they caught it very early, and she just finished treatment and is feeling great. But for me, both times I found the lump myself doing self breast exams, and I just always advocate, that early detection is so key, so important, and getting your mammograms and knowing your body. So that's just my little 2 bits from my personal experience that I just wanted to share with everybody. Also, I wanted to ask, when you are with an oncologist and you're figuring out your treatment plan, what should you do if you want to get a second opinion? Or maybe you don't like your oncologist's care plan and don't feel like it fits with your health goals. Can one of you answer that of what do you do if you want a second opinion? Who wants to go with that one?
Kristen, I'll go ahead and take that question.
Go ahead. Go ahead.
There are many times when we speak with patients that they may have a difference of opinion, or they may need to have some reassurance in terms of what we recommend. So we very often will encourage patients to get second opinions, because we think that the more collaboration we have, the better it is for the patient. Ultimately, patients need to be very comfortable with their decisions that they make. And so the more comfortable you are in terms of getting more information, if that helps you make a really good decision, that's what we want for you as a patient.
We're not going to hurt your feelings, right?
Absolutely not.
We want that you all are there for us to make the best decisions for us. All right, we have some questions from our attendees. And our first question is, I have a very close friend who is currently undergoing treatment. She was diagnosed this spring. Of course, because of COVID, we're being extremely cautious and have kept social distance. But I'm very worried about how the isolation is impacting her mentally. What resources do you recommend, or what things should I do to keep her spirits up? Dr. Sudarshan, I'm going over to you.
Sure. It is so hard when someone we love is diagnosed with cancer and we don't know what to do to help them. I would suggest that you just keep being the friend you've always been for her. Understand that she might be overwhelmed and she might act a little bit differently sometimes, but keep showing up for her as her friend. Anyone going through treatment for cancer can use a good listener, so letting her know that you're always there to do so would be wonderful. Now that it's hard to see each other in person due to COVID-19, I suggest that you call or video chat with her regularly to check in with her. Perhaps you could offer to run some of her errands or pick up groceries for her. If feasible, you could bring her a home-cooked meal once in a while or arrange a meal train for her with some other friends or family members. Showing you care by dropping off a little care package might also mean a lot. I suggest including things like warm socks, nice lotions, lip balms, a book to read, magazines, or puzzle books to occupy her while in the office getting her treatment would also be useful. Maybe a beautiful journal in which she could record her journey might also be a nice token. While on treatment, patients also need lots of water, so a nice refillable water bottle or thermos would be helpful. To combat nausea from treatment, things like ginger candy, peppermint tea, or Queasy drops will definitely come in handy for her as well. You could also encourage her to ask about cancer support services offered by her doctor's office. I know here at MedStar Montgomery, we're offering virtual support groups, guided relaxation, and gentle yoga, all of which would likely improve her mental well-being.
Thank you, Dr. Sudarshan. Sometimes just checking in, just sending a text or picking up the phone makes such the difference, especially in a time when many of us feel a little more isolated than normal during this pandemic. Dr. Song, there was a question that came in earlier for you. When is it appropriate to have 3D mammogram or MRI mammogram? How do you know what the best one is for you?
Well, all women, I think, should be getting mammograms beginning at 40. And you bring up a very good point about 3D mammography, which Tammy alluded to in the video. With that 3D mammography is the state-of-the-art mammogram. We do know that it picks up smaller cancers early, and it picks up cancers earlier, especially in women with dense breast. As I touched upon briefly, certain women, young women, who perhaps maybe would not be eligible to start mammography screening, and women with dense breast or previous history of breast cancer, women with strong family histories or at increased risk, are those who would benefit from potentially getting MRIs. Breast MRIs are the most sensitive modality we have in imaging to detect breast cancer. And that's why for us as radiologists, that's that to us is basically part of the $1 million workup. And for certain women, this is beneficial. We do have women that undergo these very vigilant screening regimens, which include mammograms alternating with MRIs at 6-month intervals. And there are studies that many of the participants, you may have seen them. JAMA came out with one in February. We are currently looking at the utility of potentially offering routine breast MRI for women of average risk and dense breast tissue. So that, I would say, stay tuned. But it goes back to what you were saying earlier, Kristen, know your body, know your risk, and talk to your doctor and the doctor that you're comfortable with to come up with a very specific, individualized precision treatment and screening plan for you.
Thank you, Dr. Song. Our next question, your advice or recommendations regarding COVID and chemo with respect to travel, visitors, life chores, what should we know? Who wants to take that one? I feel like I'm gonna roulette. I'm gonna pick one of y'all. I mean, obviously, you know, we're keeping, having to keep our distance, but when it comes to COVID, chemo, everything, let's see who wants to take that.
I'll take
that. Dr. D,
so,
yeah.
Absolutely. So, well, you know, being on chemotherapy and in the pandemic, like, you know, it's not an easy thing. Of course, you know, people who get chemotherapy are immunocompromised, so they should be extra careful with regards to where they go and what they do. But that does not mean that, like, they should limit themselves in the house and just be afraid and not go out. With appropriate social distancing, with appropriate precautions such as, you know, masks for sure, and then you know, avoidance of crowded spaces, you know, they can be safe. And of course, it depends on the type of the treatment they're getting. Some chemotherapies, you know, actually, like, you know, reduces the immunity, like, you know, more than other types of treatments. So the bottom line is that it's individualized, but I always encourage my patients to go out and be active, because that ultimately helps them go through the journey.
You know, I might add that our cancer center also has a special entrance specifically for cancer patients, so they don't go through the same line and system that our emergency patients or our routine patients might go through.
I will say that's, to have something like that is amazing. You know, sometimes you're already tired, not feeling well, or you might be going in for something quick, and just to be able to go separately and not deal with other patients that might be waiting or people walking in and out. I love that, Dr. Howard. Thank you for sharing that we have our own special entrance, something special just for us.
And
okay.
Kristen, yep. just to add to that, you know, we never delayed any treatments during the pandemic. We actually, like, you know, remain on schedule for all the treatments with all the precautions and everything that we did, and that really helped our patients to get the treatments at the same time be safe.
Awesome, thank you so very much. Dr. Sudarshan, there's a question for you. Do you recommend getting a second opinion on regular mammogram screenings? Sometimes I wonder if results are correct and have often thought about paying out of pocket for second screening at a different radiologist.
I mean, this is a good question. It's a little bit difficult. I would say that in general, what is going to be the most helpful is that when you have a mammogram, it would be compared to your previous mammogram. So whoever is reviewing it, they should always be looking to make sure that there's no change from the previous year until in this current one. If there is something felt on your exam or something like that that does not show up on mammogram, then certainly there should be further workup of that. There are cases where breast cancers can be palpable but not seen on mammogram. So certainly if you feel that something is going on and the mammogram is normal, I would still pursue that. It would probably be best to speak directly with your doctor, and they can help to guide you. Maybe it would best to have other imaging done, things like ultrasounds or MRIs. In general, I would say though that in most I guess the main thing would be is if you're wherever you're having the mammogram done, it's important to know that the person that is reading the mammograms is very experienced at doing this. But by all means, please advocate for yourself if you feel that something is off and should be worked up further.
Thank you, Dr. Sudarshan. We've been getting a lot of questions in the Q&A about The breast cancer risk in the African American community for African American women. Dr. Song, I'll go to you first, and Dr. Sudarshan, if you want to chime in, and whomever else wants to chime in with this as well. What factors contribute to African American women's higher incidence of breast cancer?
I think there are a couple of things, and we're still learning about this. One of the, and Dr. Sudarshan can elaborate more, but one of my favorite topics right now is we are finding new characteristics of cancer, so that sometimes the cancers that we are seeing in the African American population are not necessarily the same as those that we are seeing in other populations. And that's, I think, an important thing for us to remember. In terms of why we're seeing different types of cancers at different stages and why we sometimes see different outcomes in various ethnic groups, part of that, I think, comes from the beginning of the utilization of screening mammography and availability of services. I touched a little bit upon screening MRs. We are actually very interested in this because we do know that there are women, if you have an increased risk, you should be aware of that, and you should be offered the option to have supplemental screening MRs. Preliminary data is showing that not all women are equally made aware of their risk, and not all women are equally given these options. And that's something I think is a little bit deeper than the topics we can discuss tonight, but I think it comes down to how available and accessible are the tools that we have for detection, the differences in the biology of the tumors, and we need to get better, in my mind, about precision medicine to make sure that we are offering every patient everything that that patient needs, regardless of external factors. I would also like to touch just on one thing for anyone. If you have a question about your imaging study, I would speak to your doctor who ordered that study first. I would be very wary, and I would not be so eager to pay out of pocket for a second opinion first. Most physicians or most breast centers do have a multidisciplinary team such as we do, so that if someone comes to you and says, if a patient comes to someone and says, you know, I got my mammogram, I'm not really sure, what do you think? That your doctor will have a radiologist, or most likely should have a radiologist. They can go and kind of get a consult or a curbside consult or opinion from them, and that should not be at a charge to you as the patient. And I'll get off my soapbox now.
Thank you, Dr. Song. I think that that's a very good point, since you are the one that are dealing with the mammograms often, and you're an expert in that. Just to speak a little more about how breast cancer affects African American women. This is something that is a very crucial topic, and I know that we have several members in attendance today that this is directly impacting. I think the thing that is most startling is that African American women have a much higher mortality rate from breast cancer than women of other races. And the main reasons for that are that, first of all, usually these breast cancers are detected later, so that it's already more advanced. And the second thing is that we know that there is a certain type of breast cancer called triple negative breast cancer, which is more prevalent in the African American community. Now, why that is the case, we don't know exactly. As Dr. Song said, we are trying to learn that more. I think the most important thing is to know if you did have a family member that was diagnosed at a young age, especially under the age of 50, I would say. That's something that should clue you in, that should be worked up further, maybe looking at things like genetic testing to make sure you are not a carrier of a mutation. However, I think the most crucial thing that this really tells us is that we really have to encourage not only all women, but especially African American women to be getting their routine mammograms. Because to be honest, the main reason, especially for the late diagnoses, is, as Dr. Song said, unfortunately, women in this community are not getting the mammograms annually. And it's very much a failure on the healthcare system. We need to get better. So please, if you are in this community or if you have friends that are, please talk to your family members, your sister, your mother, your friends. Please encourage them to get their mammograms because this is going to make the biggest difference for you.
Dr. Sudarshan, Dr. Song, thank you very much. Dr. Howard, coming to you, I have a couple questions for you real quick. How effective is a mammogram with implants? Can a mammogram see behind the implant, or is there another method that's more effective with implants?
Yeah, reconstruction, well, implants with augmentation or implants after breast reconstruction really don't affect the efficacy of the screening, but it changes the technique that's used, really. So they have to alter the technique for the mammogram and also introduce other types of screening, such as MRI, to get a very efficacious screening for both cancer in the setting of augmentation or cancer as a recurrence. So it still works, still recommend mammograms in women with implants, very important. And there's screening after reconstruction that varies by the type of reconstruction, but we still definitely want to continue screening for recurrence after a diagnosis.
Great information. I have another one for you. Does breast reconstruction surgery increase the risk of developing breast cancer in the future?
So it does not. I think those questions are a bit related. Breast reconstruction does not really alter our effectiveness in determining recurrence of breast cancer. There was a reconstruction that used a type of implant that was implicated in causing a really, really rare type of lymphoma. And, 1 in 30,000 to 1 in 300,000 rate of incidence with a specific type of implant. That implant is no longer used. And if you look at the rate of occurrence of breast cancer as 1 in 8 or 1 in 9, it's exceedingly rare form. But the answer is no, it does not increase your risk for cancer.
All right, thank you so much. Dr. Ampe, I'm coming up to you. The question for you, what role does the environment play in contributing to an increased risk in breast cancer, i.e. the products we use, like deodorant? I remember the first time I was diagnosed, my oncologist, she was convinced that deodorant, not necessarily was why I got it so young, but a contributing factor sometimes. So where do we stand when it comes to environmental impacts?
I think clearly environment plays a role in the sense of healthy habits. We hear the deodorant thing all the time. My wife is an OBGYN, and she actually has heard that multiple times. We really don't have any evidence that that's the case. But certainly what we know is that healthy habits, keeping your weight down, weight control, exercise, those things are vitally important.
Great, thank you so very much. Dr. Sudarshan, coming back to you. What age is appropriate for screening for the BRCA gene?
Okay, so let's see. Usually a person that, first of all, we wouldn't test for a BRCA gene in everybody. It is often checked in patients that are newly diagnosed with breast cancer, depending on the history and such, age of diagnosis and all of that. However, if you do have a strong family history of breast cancer, the first option I would propose is that if it was, let's say, your mother or someone that is close to you, you could see if, first of all, they could be tested, or if they were tested. If they were not tested, it might be, if they're still in contact with their oncologist, it might be easiest for them to get tested. However, if they have not been tested, or it's not possible to test them, and you still do have a strong family history, I would definitely speak about it with your OBGYN or your primary care doctor, and they would be able to refer you to myself or someone in my field that would be able to help with this. There's not a specific age per se. what I would say is, in general, usually anybody that we would consider higher risk, if they had a first-degree relative like a mother or a sister or something like that, diagnosed with a breast cancer, we would usually recommend a lot of your screening things, at least, well, starting around 10 years prior to their diagnosis. So let's say if you had your mother, I can speak in myself, my mother had been diagnosed at age 43. So in theory, I should start doing a lot of my screening types of things at age 33. And probably around that time, as you start that would be a good time to bring this up about the strong family history, and if it seemed appropriate, potentially get tested for the genetic screen.
Thank you, Dr. Sudarshan. Dr. Ampe, I want to come back to you real quick, because you mentioned the healthy lifestyle and exercise, and this being Breast Cancer Awareness Month, you know, it's been a topic of conversation, especially with pandemic and cancer diagnosis, of staying active and the importance of exercise. Is there any thoughts on things you can recommend on exercise for patients at various stages of treatment and recovery, and what kind of resources are out there? I know some women have to worry about lymphedema. Like, what can you share in terms of the importance and how much we should consider?
That's a great question. One of the things that MedStar offers is something called cancer rehab. And I say rehab because that's what it's called, but there's actually what we call cancer prehab, cancer rehabilitation. And so these are actually physical medicine and rehab physicians who actually specialize in developing exercise programs for people who have finished treatment before they get treated. And we even can refer them to get opinions during the time that they are treated. For me, in my practice, I try to make sure that patients continue to keep up the habits that they would like to keep up. I don't like to tell patients that you can't do things. We don't like to take things away from patients. We like to continue to encourage that. There is a limit to what we recommend, though. So if a patient's undergoing chemotherapy and they're getting fatigue, if they're undergoing radiation getting fatigue, we don't want you to burn yourself out, but we don't want you to kind of hold back either. So exercise programs, which can be anywhere from walking, they could be light weight training, they can be yoga, they could be stretching. Any of those things we like to recommend, because we don't like to see people get too debilitated during the course of therapy, such that they have a very hard road to recover. But if they do, we'd like to refer them over to our colleagues who do cancer rehabilitation for those individualized programs that actually help them get back into shape. In addition to that, there are many complementary therapies that we recommend during the time that patients are getting treatment: massage, Reiki, things like that, which can also help keep patients limber, can actually help them with the mindset of getting through cancer as well. So physical and mental aspects are very important for patients to get through treatment.
I'm 3 years out from my surgery, and I still use that as an excuse to go get a massage every month. So I'm going to keep doing that. But it's because it's something that that stays with you, and you're still recovering from whatever your treatment is. So I love that idea, just to keep moving. But obviously, each patient is individualized in their own efforts. We have another question for Dr. Song. This question says, in the past, I've always heard things like how much a mammogram hurts, or that if you have smaller, denser breasts, it can be even more painful. I'm embarrassed to say that hearing this made me push back my exam a couple years until I had to do it as part of my employer's wellness requirement. I turned 40 this year and had my first mammogram a few months ago, and it really was not that bad, just a little soreness. What factors influence the level of comfort and discomfort for a mammogram?
So I think a couple of things. One, it's the technologist and technique. And part of that involves if you have an experienced technologist or not. That's not something that you necessarily have in your control. Mammograms can be more uncomfortable depending on sometimes where you are in your cycle. And quite frankly, we used to only do mammograms using one type of paddle or compression paddle. For women who've had mammograms, you know what that is. That's the rectangular piece that comes down and actually does the compression part. We have gotten better at it, and now we have what we call a curved paddle, which is a little bit gentler and quite frankly more in line with what the natural breast looks like. Most women do, there are certain women, and let me backtrack that, are not eligible to use this curved or smaller paddle, but I would say in our experience, about at least 80% of women can get mammograms with the more comfortable curved paddle. So we are getting better at it. A lot of it though is the personnel and the technology.
Great, Dr. Song, thanks so much. Dr. Sun, this question is for you. How do you decide a full mastectomy versus a partial, one breast versus both breasts? What comes into play there?
Yeah, thank you for that question. I think if a cancer is small enough and the patient desires to keep her breast, we always err in the less is more. If you want to keep your breast and that's very important to you, we always decide on breast conservation therapy. However, sometimes we choose a full mastectomy in certain settings. So for example, if the cancer involves multiple aspects of the breast and we cannot leave a cosmetically good-looking breast, some patients opt for a mastectomy. Now, the second question is one versus two breasts. Most patients who have a genetic predisposition, like BRCA, for example, opt to have a bilateral mastectomy. The reason being is because they remove that risk of having breast cancer in the future. And so for those reasons, some people are eligible for bilateral mastectomies.
Thank you, Dr. Sun. Dr. Sudarshan, I wanted to come back to you real quick about something you said when we were talking about the genetic testing. And I know the first time I was diagnosed, so I was 27, so they did the genetic testing, didn't have the gene, didn't really have a family history. The second time I was diagnosed, about 7 years later, they recommended the genetic testing again, because the scope of what's being tested for had increased dramatically. So if someone had genetic testing 5 or 10 years ago, should they be retested because of new testing developments? And where are we in terms of kind of what we're testing for?
Yes, this is such a great question. This is definitely something that we encounter relatively commonly in some of our patients that have been tested before, and they ask this question. We have really expanded the number of mutations that are in this panel in patients that have developed breast cancer or are at high risk of breast cancer because of a family history. The testing years ago mostly was just including BRCA1 and BRCA2. Now we do have a lot of other mutations that are included in there. Not all of them are things that we have specific targets for per se, but at the same time, they help to inform us whether or not patients are at higher risk for breast cancer. And if a patient has already been diagnosed with breast cancer and they have this mutation, it obviously is helpful to inform family members so they can also be tested to know their risk moving forward. I think it's something that we're going to continue to see improvements. This is going across the board in oncology. We are really going towards more personalized medicine. A lot of our cancer types, not even just breast cancer, but a lot of tumor types, we're starting to look very much at the specific mutations driving the tumors, and that really helps to inform us about how to best treat them.
Thank you, Dr. Sudarshan. Dr. Howard, I'm going to come to you for this final question. They ask, can you have reconstructive surgery 30 years after having a mastectomy for breast cancer? Is there a best time to have the reconstructive surgery for it to be most successful? And I'm actually going to add on that, Dr. Howard, because with certain treatments, obviously it affects the breast, those that have had reconstruction or were able to, nipple sparing and whatnot. So is there a time frame you guys look at for those that maybe have just gone through it when maybe they could get reconstruction and feel a little bit better about what they have?
Sure, I'll answer the first question. Is 30 years too late? I would say it's not. In fact, the Women's Health and Cancer Rights Act of 1998 really guarantees your right to have reconstructive surgery and also symmetry surgeries. So for example, if you have a unilateral procedure and it's made one breast smaller than the other, you can have a symmetry procedure and they should all be covered by insurance under this Women's Health and Cancer Rights Act. So it's not too late, and I have a lot of patients that might opt for no reconstruction initially at the time of mastectomy, and after a few years of living with a mastectomy deformity, elect to have reconstruction. And those women are very gratifying patients. The best time to do reconstruction, really, I think, is to start at the time of the oncologic procedure. And this gives us the ability to do, like you suggested, preserve the nipple, preserve the, what we call the skin envelope. I know that's an odd name, but the skin of the breast as best we can, and try to replace the volume of the breast with either an implant or your own tissue. And so starting early does help me, but otherwise, at any time, I think we can get really great results that help women feel normal after cancer.
A quick follow-up on that, those that have had reconstruction and maybe are 10 years out and have the implants, is there a time frame you recommend to replace the implants? Where are we with that?
You know, I think there's some surgeons that recommend 10 years implants be evaluated for their integrity. And there's some that even recommend that they would be replaced at 10 years. But I think they should at least be evaluated. Implant technology has changed quite a bit, and the modern implants with the cohesive gels and the type of silicone that doesn't run, it all holds together. These are what I might call lifetime implants, and they don't need to be replaced. They just need to be evaluated and make sure that they're intact.
Great, thank you. Yeah, I'd always heard the 10-year rule, so to speak, but I know with the advancement of implants and technology, so I wanted to get your take on that. Thank you to all of our viewers for your great questions. Thank you to all of the doctors for your great answers and insight. Before we leave, I want to give each of you a chance to just have, if you have any final thoughts that you want to share with everyone tuning in tonight. Dr. Ampe, do you mind if I start with you for some final words?
I think one of the most important things from tonight is being able to see all the panel members and recognizing that the treatment of breast cancer is a multidisciplinary endeavor, and so that there are many partners, many collaborators in taking care of patients. And so that's the thing to appreciate from looking at the panel tonight.
Awesome, thank you so very much. Very, very true. It takes the team to do it. And I could say, being on with this team beforehand, you all like each other. We were having some fun beforehand. So it's nice to have a good team that works well together and that you can bounce ideas off of each other. Dr. Song, I'm gonna come to you. Any final thoughts?
I think it's important for people to realize that you can get world-class comprehensive care in your backyard. And that is really a blessing that cannot be stressed enough. And this, again, as you mentioned at the beginning, we all work at different sites. Sometimes we all have experience coming from the big academic center and to working at MedStar Montgomery Medical Center. And I will tell you, you have world-class doctors. You've seen this panel. These are wonderful people who are world-class doctors here for you in your backyard. And I think that I would just encourage all the participants to take advantage of that.
Well said, Dr. Song. Thank you so very much. We are very blessed to have this medical expertise in our backyard. So thank you so very much. Dr. Duratage, I'm coming to you. Any final words? I think you're on mute. That's okay.
Sorry about that. So aside from the venerable panelists that are here, I just want to mention that the whole, breast care team and the cancer care team has a lot more people, and it actually, involves social workers, clinical nurses, infusion nurses, And also we have patient navigators. In fact, one dedicated, for breast care, the breast care, and then one dedicated for oncology care, and they work seamlessly with the physicians to provide the best care possible. So I think, I just wanted to make sure that I mentioned the whole team, aside from the panelists, tonight.
Dr. Duratash, thanks so much. Dr. Sun, I'm coming to you.
I just want to say thank you to all for logging on to join our webinar. Breast cancer is a very complex subject, and it's constantly changing and evolving, and all of us are always keeping up to date with everything that is published. And so I just want to say that we aim to treat all of the patients individually in a multidisciplinary setting. And especially in the COVID era now, we just have to learn to coexist with it. And so we've put all of these precautions to make sure everyone around us is safe, and I just don't want anyone to delay their care for that reason. And so we're all friendly faces. Please come see us. Screening is important, and so thank you for logging on.
Thank you, Dr. Sun. One of the participants said we are so lucky to have all of you in Olney. So just wanted to reiterate what you all have been saying. Dr. Howard, I'm going to come to you. Any final words?
I'm really excited to be a part of this team, and I think I'm really proud that we can offer a complete spectrum of care here in Olney with not only, like Dr. Duratash mentioned and Dr. Ampe mentioned, a great team dedicated to breast health here in Olney, and really proud to be here. So thank you all for joining our webinar.
Thank you, Dr. Howard. Dr. Sudarshan, you want to wrap us up with some final words?
Sure, thanks, Kristen. Thank everyone so much for coming. We're so happy that we had this chance to speak with you, and hopefully it was beneficial for you. The main takeaway I would say is that breast cancer doesn't wait while we deal with COVID-19. So please don't delay your necessary health care, including your annual screening mammogram. And if you can, please also speak to at least one or two of your friends that didn't attend tonight, and also pass this message on to them. Please mask up and mammo with us.
Thank you, Dr. Sudarshan. Great words to leave us with. Thank you to all the participants. Thank you for having me and letting me be a part of this conversation. I'm going to send it back over to Tanya now to wrap us up and give you some information of where you can go to reach this team and the rest of the breast care team. Tanya, I'll send it back to you.
Thanks so much, Kristen, and to all the panelists. Kristen, thank you for leading this discussion around a topic that is so personal and so passionate for you. We really appreciated your insight, and you just did a great job with working with all of our panelists this evening. Thanks to all of the panelists for your participation. And I'd like to just share a little bit of information with our attendees on how you can get more information. Our telephone number, if you'd like to call to schedule a mammogram, is 301-260-3301, or you can visit medstarhealth.org for more information on our Breast Health and Imaging Center. Finally, thank you to all of our panelists, our partner, the members of Alpha Kappa Alpha Sorority Incorporated, and to all the participants. Good night and be safe.